As usual, where is our madam? Madam is missing. Call her.
Between rounds, sir. Rounds.
Rounds. But always she was rounding very late, no? Okay. Practical and easy approach to platelet function and coagulation. Tell me which discipline in medicine doesn't require to know this? Every person in medicine, every student, every postgraduate must learn this because it is applicable one way or the other. You can see that music concert. Do you think we are going to play some music now? No. There are three people. One lady is singing and one violinist and one mridangam. That means there are three performers in the clotting process. The platelets cells, the clotting factors, and the vessel wall. Okay? But the vessel wall and the clotting factors are accompaniments. Platelets and cells are the main singer. Okay? Now, container and the content. Container is the vessel, content is the blood. This blood contains both platelets, cells, and then the clotting factors. Okay. You're not able to see anything. Okay. Is that good enough? No. We could do one thing. So many windows are obstructed. Okay. Now look at this diagram carefully. Antiplatelet drugs, anticoagulants, and thrombolytics. What are they? What are antiplatelets? What are anticoagulants? What are thrombolytics?
Prevent platelet adhesion.
Antiplatelet drugs prevent bleeding. Okay? And immediate repair. There is an immediate force to repair any vascular damage. They are the antiplatelets. Anticoagulants, what are anticoagulants? Those which prevent formation of clot. Okay? So you have a mitral valve, prosthetic valve. You don't want clot to form on that. You will give anticoagulants. A person has got atrial fibrillation. You don't want a clot to form in the left atrial appendage. You give anticoagulants. Their antiplatelets have no value, mind you. What are thrombolytics? Already clot has formed. You want to dissolve it. Myocardial infarction. There is a thrombus in the coronary artery. Use a thrombolytic agent, streptokinase, ureokinase, or tenecteplase, whatever it is, and then cut the thrombus. So basically, majority of the people, they don't understand the difference. They all call blood thinners. There is nothing like a blood thinner. The blood can never become thick or thin. So, okay, it's a misnomer to say blood thinners. Antiplatelets are those which are helpful in preventing aggregation of the platelets in unnecessary sites, like coronary vasculature or any endothelial surface. Anticoagulants are substances which prevent clot formation, and they are useful for as a prophylactic agents in many conditions. Thrombolytic agents are those when the clot already occurs, you want to dissolve the clot, you have to use the thrombolytic. At atrial fibrillation, you can't use a thrombolytic agent. Okay. Likewise, acute infarction, you can't use an anticoagulant alone. You have to give anticoagulant and also give a thrombolytic agent. So, first thing is A. A is adhesion. activation, aggregation. Three things happen. A, adhesion, again another A, activation, another E, aggregation. So first the platelet goes and touches the surface of the endothelium. It adheres. Once it adheres to the endothelium, endothelium will shout, "Why are you touching and me? Why are you getting attached?" Then platelet gets activated. Yeah, it is scolding me, and it will start shedding lot of tears. And those tears are the chemokines. These chemokines attract more platelets to fight with the vessel. This vessel fellow is sending me out and is not allowing me to sit on the vessel. You people come and do something and obstruct the vessel itself. And then the aggregation takes place. Adhesion, activation, aggregation of the platelets. That the exposure of the acidic acidic phospholipids. So once this occurs, the acidic phospholipids of the platelets are exposed out. Then what will happen? This platelet secretion of preformed mediators, particularly ADP and the synthesis of various mediators, thromboxane A2 and then PAF, platelet activating factor. So once these activation means it produces mediators which are ADP and then the thromboxane A2 and then the platelet activation factor. Then what does it do? It calls more platelets. That is called further aggregation of the platelets. Okay. Now, this exposed acidic phospholipids, they trigger the clotting cascade. So there are two pathways there. One is called the in vivo pathway, the other is called the contact pathway. So these pathways we are going to discuss, which ultimately lead to clot formation. There are three basic levels. First level is factor 10 has to become 10A. That is the first step in the coagulation. Second step is this 10A should act on 2 to become 2A. Okay, 2 is thrombin. Thrombin has to become 2A. Okay, this 2 has to act on 1, which is fibrinogen, to convert into fibrin. So what are the three steps? First, 10A is sitting there, circulating in the blood. That is 10. That is factor 10. This factor 10 doesn't do any harm when it is circulating. Once it is activated, it becomes activated 10A. Then it goes and targets the thrombin. Is that the thrombin fellow is sleeping? No, you get up. Thrombin gets up. Then that becomes activated. This activated thrombin or 2A goes and attacks the fibrinogen and splits some polypeptides from it and makes it into fibrin. Fibrin is a mesh and the fibrin entanglement occurs and the fibrin mesh forms into which all cells are embedded and produce a thrombus. So this is together, the platelets have to be activated. They have to secrete acid phospholipids. Acid phospholipids have to act on 10 to become 10A. Not only that, 10 to become 10A, several steps are there which make the 10 to become 10A. So 10 is the final common pathway. 10 to 10A, 2 to 2A, 1 to 1A, clot formation with entanglement of all the cells in the mesh. This is in general. When this occurs, when there is a breach in the endothelium. Suppose you have a cut. Immediately after 5 minutes, you don't bleed. Why? Because there is a breach in the endothelium. It triggers platelet activation, platelet aggregation, adhesion, activation, aggregation, and that produces more platelets and all the chemokines there. They produce the acid phospholipids. Acid phospholipids trigger the clotting factors. That is 12-10 becomes 10A, and then that 10A acts on the 2 to become 2A, and the 2A acts on 1 to become 1A, fibrinogen to fibrin, and the clot forms. That is why you measure two things, bleeding time and clotting time. కొంచెం వెనక్కి రండి, ఆయన ముఖం కనపట్టలేదు నాకు. మీరే కొంచెం వెనక్కి కూర్చోండి. So that I can see. Yeah, otherwise I don't know if he's sleeping or not sleeping. If he's sleeping, fine. Okay, now this part you have understood. Now tell me what are the three steps, basic steps in coagulation?
Adhesion. Activation, aggregation.
4 steps: platelet part and then clotting factor part.
Platelet formation, primary hemostasis, secondary hemostasis, extrinsic pathway, intrinsic pathway, and then common and fibrinogen pathway.
3 A's: adhesion, aggregation, activation. And then that produces acid phospholipids. These act on 10 to become 10A, 10A acts on 2 to become 2A, 2A acts on 1 to become 1A. Fibrin is formed. Cells are already there. What is required to produce a clot? That's all. Clot is there and the vessel is sealed. No more bleeding. So, if you do a bleeding time, it measures this part, the orange part. If you do a clotting time, it measures the other part. Understand? That's why bleeding time and clotting time. Okay, bleeding time prolonged, clotting time normal, means platelet dysfunction. Bleeding time normal, clotting time prolonged, clotting mechanism dysfunction. Both prolonged, entire chain is dysfunction. Functional importance is there for everything. Now, so the coagulation cascade. What is cascade? What is the word by cascade? Free fall. You have anybody seen any waterfalls or anything? That is the water freely falling. That's a cascade of water. Cascade means free fall. What is that free fall? There are 2 pathways: intrinsic pathway and extrinsic pathway. Why intrinsic pathway is required? Intrinsic pathway is required to rectify all the damages that regularly occur inside the vessel. Extrinsic pathway is required when something from outside happens to the pathway. The extrinsic pathway is triggered. Both the pathways are like Y, and the Y's meet at the junction that is called the X or 10. Whenever there is a crossroad, it's called X, no? Junction. That junction is the 10. Okay, so this is intrinsic pathway, extrinsic pathway. 10 by itself is not clot. 10 has to again act on thrombin. Thrombin has to become activated thrombin. Activated thrombin should act on the fibrinogen. Fibrinogen has to become fibrin. Then fibrin mesh has to form. Then that is the clot. And all that after 10A to fibrin and clot is the common pathway. Extrinsic pathway on the left side, intrinsic pathway on the right side. Common pathway is the blue one. The orange one is the extrinsic pathway. The intrinsic pathway is the yellow, green one. And the common pathway is the blue one. And finally, the clot formation, and then lot of fibrinogen, fibrin, clot formation. Not only the clot forms, what does the mason do while he is constructing the wall? He will take cement and then put it on the wall. And then whatever cement is required, he will keep, and extra cement he will scrape off. That scraping off is called fibrinolysis. That means extra clot is wiped off by the fibrinolytic mechanism. Otherwise, suppose small hole is there, this much big clot comes, it will be a problem. So whatever extent is required, the clot remains. Everything else is shaved off by the fibrinolytic pathway. So extrinsic pathway, intrinsic pathway, common pathway, fibrinolytic pathway. So these are cascade. Cascade means once something starts, it will go like tuck, 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 it will go to the last step. And then somebody has to tell, no, stop. We have enough of clot here, enough of platelets here, no more required. This is called the feedback inhibition. Okay. The feedback thrombin is the potent feedback inhibitor also. Thrombin is required for clotting, and it is the potent inhibitor of further cascade. So there are 5 mechanisms are there: extrinsic pathway, intrinsic pathway, common pathway, fibrinolytic pathway, and feedback inhibition. The orange one is the extrinsic pathway, and the green one there is the intrinsic pathway. And then finally the common pathway, the blue one, the yellow one is the total formation of clot. Okay, we have understood this till now. Now you see. So there is a lesion in the blood vessel. There is a cut in the endothelium. What will be the first reaction before the platelets come? Vasospasm. The body reflexively contracts the blood vessel so much so there is no oozing or bleeding unnecessarily occurring. That's the first step is vascular spasm. Then what happens? Platelet formation. That is plaque formation. The plaque will be formed, but that plaque is made up of platelets, and then the platelets are white clot. Platelets are called white clot. They cannot hold for longer time. There are a lot of holes in between them. They cannot prevent the bleed completely. Then the fibrin has to come and support the platelets to form a firm red clot. White clot is the platelet clot. Red clot is the fibrin-rich clot. Okay, you see the first one, there is a vascular damage is there, activated platelets are there, they have produced the thrombin is stimulated, fibrinogen is converted to fibrin, and then you have the fibrin mesh in which the red cells are entangled and the leak is sealed. What happens after a few hours? The excess clot is removed by the fibrinolytic thing, and only the breach is bridged. This is how it occurs. Okay, now let us see. That is the close-up of the fibrin mesh. How the fibrin will form, the fibrin monomer will become fibrin polymer. The polymer of the fibrin is very tough like a mesh in which the cells are entangled. Now you see. So we have got the white blood cells, we have got the red cells, and on the electron micrograph of the platelets here. These platelets, when they are not activated, they are like this. So the inactivated platelet is like this, activated platelet is like this. It develops a lot of connections, something like pseudopodia. And then this is an activated platelet. Why it is required? What are all these hands for that? To shake hand with the neighbor platelet. So this platelet has to shake hand with the neighbor platelet to form adhesion. And then aggregation has to form. For that aggregation, the activation is required. First adhesion, then activation, then aggregation will occur. So the aggregated, you see how the electron micrograph schematic representation of how they are entangled, embracing one another and forming a link like this. Now, what is hemostasis? Hemo, blood, stasis, stopping. Hemostasis is stopping of the unnecessary blood oozing. What are the main steps? First one is vascular spasm. 2. Platelet adhesion. 3. Platelet activation. 4. Platelet aggregation. 5. Platelet plug or soft clot or white clot. Platelet blood coagulation, firm clot or red clot, and then clot lysis and retraction. These are the various steps. As you can see here in your picture here, you can see you start with the platelet. So there is what the platelet is there. The platelet is activated, and there are several factors which we'll come across in the next slides. Ultimately, our job is to get 10 to 10A. If 10 becomes 10A, the clot can progress. So how 10 becomes 10A? There are several steps are there. And there are cutting scissors are there to remove the excess clot. That is called plasminogen. Plasminogen means it generates plasmin. Plasminogen, when it is activated, it becomes plasmin. Plasmin is the scissors. The scissors cuts the extra clot. Okay. The tailor, what he will do, if you give the cloth to the tailor to stitch your shirt, he will keep only the required portion and he'll cut other things and throw it away. No, why are you wasting my precious cloth? All my cloth is in the dustbin. You should not say. Unless he removes that, shirt will not come. Otherwise, he will say, no, then you take your cloth. I will not be able to stitch. So that plasmin pathway is as important as the clotting pathway. There will be defects in the plasmin pathway also. Okay, now, what are platelets? Platelets are unpigmented, enucleated cells that are fragments of larger progenitor cells called the megakaryocytes in the bone marrow. You can see here, this is the megakaryocyte and it is a large cell. In fact, the largest blood cell that you can see in the bone marrow is the megakaryocyte. Okay, it sheds the small tiny platelets because they are small lets. They are let out to go. That's called like plates. This are platelets. You see the RBC compared to the RBC of 7 microns, these are around 2 microns in size. Okay, once bound, they release thromboxane A2 and serotonin. Very two important powerful powerful mediators that induce vasoconstrictor. What is the purpose of thromboxane A2? It is a vasoconstrictor. Okay, serotonin also is a vasoconstrictor to reduce the blood flow and to increase the platelet aggregation. Okay, these are the two things that happen. Oh, now you see. Subendothelial cells. So there are some cells under the endothelium. When the endothelium is damaged, subendothelium will not keep quiet. It also tries to do its best. What is that? Certain extracellular matrix and proteins called collagens are normally they are not in contact with the blood. Why? They are subendothelial, below the endothelium. But when the endothelium breaches, the subendothelial factors are available for the blood to be activated. There comes your von Willebrand factor. That von Willebrand factor or VWF, small VWF, is when exposed after injury, platelets aggregate at the site of mediation of von Willebrand factor that both binds the platelet receptors and the collagen in the subendothelial tissue. You imagine, so let's say this is the blood vessel. Okay, look at me. There is a breach here. Subendothelium, there is von Willebrand factor. That will have two arms. One arm will catch the collagen. The other arm will catch the platelet. And then bring. If von Willebrand factor is absent, what will happen? Platelets are good, clotting mechanism is all right, and collagen is there in the subendothelium, but there is no one who is going to handle these two fellows and bring them together. That is why von Willebrand factor deficiency is a disease. What is von Willebrand factor? It is a large multimeric protein with several subunits under it. So now we have learned one more step. There is another thing also required other than platelets and all the mechanism. There will be tissue factors or the endothelial factors, subendothelial factors, primarily von Willebrand factor and other collagens and other proteins. Function of von Willebrand factor, it will have multiple hands. With couple of hands, it holds onto the collagen. With the other hands, it catches 5 or 6 platelets and brings them together. You understand? Now, this is all physiology. Going back to Weston Taylor's physiology book, this is a wonderful way we have to learn these things. What is factor 1? Fibrinogen. Why it is called factor 1? Because without fibrinogen, clot cannot form. Okay, what is the next factor? Prothrombin. Prothrombin to become thrombin, that is activated thrombin. Prothrombin to become thrombin is activated thrombin, that is required for the fibrinogen to become fibrinogen. What is third factor? Tissue thromboplastin, also called the tissue factor, TF. What is tissue factor? There is a factor in the subendothelium which converts the thromboplastinogen into thromboplastin. And that thromboplastin is required for activation of 10 to 10A. Tissue factor is required for the activation of 10 to 10A. 10 to 10A is the final step. For that, tissue factor is required, ionized calcium is required, labile factor called AC globulin is required, factor 5, and there is no factor 6 today. They used to think that there is another factor, labile factor is separate from AC globulin. Now factor 5, also called factor 5 laden. You will be seeing several reports, factor 5 laden. Factor 5 laden is called the labile factor, whereas tissue factor is a constant factor. Then there is also called the SPCA, proconvertin. It's also called the stable factor, a labile factor and a stable factor. There is another factor called the antihemophilic factor or AHFA. Antihemophilic factors are 2 in number. One is called AHFA, the other is called the AHFB. AHFB is factor 9 or Christmas factor, also called the PTC. Okay, and 10 comes the Stewart power factor. Stewart power factor is the final one, and plasma thromboplastin antecedent, that is called AHFC, that is called antihemophilic factor C. After that, there is what is called the Hegman factor, and Fitzgerald factor is the 12th one. Now I'll explain you what each one will do. We know we wanted to form a clot in a particular place. Okay. Clot to form, I have to have the fibrinogen to come to fibrin. For fibrinogen to fibrin, I require an enzyme called thrombin. This thrombin is produced by activation of prothrombin to thrombin. This prothrombin to thrombin is catalyzed by 10, which has to become 10A. 10 to 10A is the final step. But how come the 10 comes? 10 requires support of several factors like ionized calcium, Labelle factor, proconvertin, antihemolytic factor A, B, and C. The 10th factor now becomes 10A. 10A now activates the prothrombin to thrombin. Thrombin is activated, thrombin now acts on the fibrinogen to produce the fibrin. That is called the contact factor or the Hegman factor. Hegman factor role is to bring the fibrin meshes together, and Fitzgerald factor is called the fibrin stabilizing factor. These are the 11. Now I am unsharing to tell me the factors. Okay, sorry. Now tell. What is happening? First, who is the most important fellow? At 10 to 10A, the crossroad. How does 10 become 10A? You require several assistants: calcium, ionized calcium, AC globulin, Stewart power factor, antihemolytic factor A, B, C, and SPC. All these together will help the 10. And 10 is Kumbhakarna. He will be sleeping always. To get him up, you require so many people to make him awake, and 10 years. Now it will not keep quiet. It is the most powerful factor. Earlier, when we were students, there are no 10A inhibitors. Now we have got direct 10A inhibitors. We can inhibit the 10A directly. You are at a great advantage. Okay, this 10A, once it is activated, 10A, this acts on the prothrombin to become thrombin, which is activated thrombin. This thrombin acts on the fibrinogen to convert to fibrin. Then the Hegman factor will come, and the Fitzgerald factor will come, and the clot is formed. Now, for 10 to become 10A, there are two ways: intrinsic and extrinsic. Okay, let us see them. Intrinsic pathway and extrinsic pathway. How to remember? It's a very difficult thing. This particular representation is thought of visually for the students to really remember what is the final way of understanding the clotting. Lot of work went into this. I liked this so much because lot of work went into this. This slide we have already seen. Now let us see the next slide. Intrinsic pathway, extrinsic pathway. Write that on the top: intrinsic and extrinsic. Coagulation simplified by Dr. Sharma. Can't find anywhere like this. One is called the PTT pathway. What is PTT? Partial thromboplastin time. The other is called the PT pathway, prothrombin time. You may not know the difference between partial thromboplastin time and prothrombin time. When to order what, you may not be knowing. How to interpret the result, you may not be knowing. The purpose of the lecture is to train you about the PTT pathway and the PT pathway, intrinsic pathway, PTT pathway, extrinsic pathway, PT pathway. If I want to test the intrinsic pathway, I must do partial thromboplastin. If I want to test the extrinsic pathway, I must do the prothrombin time. Okay. Which do you think have a longer chain of events? Intrinsic or extrinsic? Obviously, 3-letter one has got more. 2-letter one has got shorter arm. Very easy to remember. PTT has got a longer chain. PT has got a smaller chain. Okay. Now I have removed intrinsic, extrinsic, and I call them as PT pathway and PTT pathway on the left, PT on the right. Now, both these pathways, the purpose of the pathways is to get up Kumbhakarna. That X fellow should become XA. And X is marked because it is factor 10. And it is the crossroad because it is where both the factors are required to join. These two are, that is the common pathway starts from the X. Either it comes through the PT pathway or PTT pathway, it must meet at the X. And that is why it is called the crossroad or factor 10. Who makes the XXA? The PTT and the PT pathways. Okay. Now there is a V-like thing in the X upper part. Okay. So that is 5. V is 5. So that is factor 5 is required. Immediate important thing is you can see the factor 5 sitting right on the X. So factor 5 is the essential thing, also called aciglobulin, also called Leyden's factor. Factor 5 is a cofactor for the activation of X because V fits into X. Remember like that. Okay, V is 5. Okay, now once this X is activated, prothrombin is attacked and thrombin is. Okay, so factor 10A converts prothrombin or factor 2 into thrombin, the most important enzyme on the planet. Thrombin is the most important enzyme on the planet. There is no powerful enzyme than thrombin. And this itself is a feedback inhibition for the coagulation cascade. The moment thrombin is seen, fibrinogen will not be able to be separate. It becomes fibrin and mesh is formed. Okay, that is why the myocardial infarctions are occurring so frequently. Once the thrombin is formed, there is a fibrin will come and the platelets will entangle and a block occurs. That is why sudden cardiac deaths all are coming because of the very powerful thrombin. Hitherto, what did you learn? Now, why I am asking you to repeat is you must learn by heart. 10 has to become 10A. For that, there are two ways. One is the extrinsic pathway, one is the intrinsic pathway. Intrinsic is called the PTT pathway, extrinsic is called the PT pathway. Extrinsic pathway is shorter than the intrinsic pathway because PTT 3 letters, PT is only 2 letters. Easy to remember. Then what is the most important cofactor for 10 to become 10A? 5. Because half of 10 is 5. You remember like that. The half of that is 5 and that is a V and V sits nicely in the X there and converts 10 to 10A. And prothrombin is activated to thrombin. Thrombin activates fibrinogen to form fibrin, Hagman factor and then Fitzgerald factor will complete the rest. Now, is that all? Then there's nothing else. 5, 10, thrombin, prothrombin, fibrinogen is added. No. Even if the factor 5 is there and X has to become XA, several other cascades are required on the left side as well as the right side. Now that's the next step. Thrombin acts on the fibrinogen to become fibrin. Now you see. Coagulation simplified. We are now looking at the right side pathway. That is PT pathway. That is prothrombin pathway. What is the important factor there? Factor 7. PT is one less letter than the PTT and PT values are shorter than the PTT value. If you take a measurement in the lab, PT values are much shorter than the PTT values. It is a longer value there. Time. Prothrombin time is much shorter compared to partial thromboplastin time. It means that the PT pathway is also shorter and this is lucky. So the lucky PT pathway uses the lucky factor 7 to activate factor 10. 7 is considered as a lucky number in many mythologies. And we also have got Sapta Rishis, all that so many 7 associated things. In fact, the 7 days in a week is also not 6 days. Why not 8 days? 7 is a lucky number. So the lucky number is required for the PT pathway there to activate the 10 with the help of factor 5. Okay. Now we go to the left side, the PTT pathway. So what are all consumed? 7 is over, 5 is over, 10 is over. What else? What is remaining? Remaining is 12 is there, 9 is there, 11 is there, 9 is there, 8 is there. Isn't it? 12, 9, 12, 11, 9 and 8 in that order. Okay, 12, what is the first letter? T. 11 what is the first letter? E. 9 what is the first letter? N. Next letter is 8. E. And finally T. Tenet. If you remember tenet, you remember the order. That is 12 becomes 12A, 12A adds on 11, 11 becomes 11A, 11A adds on 9. Why not 10? 10 is already there, 10 is going to be used later on, 10 is not here. So 11 to 9, there is a skip there because 10 is the main crossroad. It is in the crossroad, it is not in the intrinsic pathway. So 9 to 9A and then 7, 8 to 8A. Now, for factor 10 to become active and convert prothrombin into thrombin, it requires what are all the factors required. Now, you tell me what are all the factors required in the intrinsic pathway. 5 is required, must. In addition to that, T, E, N, T. 10. T is 12, N is 9, T, N. And then N is E is 11, then 9 and then 9. Where is 7? 7 is on this side, sitting on the other side. So 7 doesn't have to do anything. If you find a deficiency of factor 7, it will not affect the partial thromboplastin pathway. If all these fellows 12, 9, 11 and 8 are also deficient, intrinsic pathway will still work because it doesn't require these fellows. Okay, these are not required for this one. That PTT pathway has all the hideous Roman numeral. Like, how are you going to remember them? Come. Tenet. 10, 12, T. 11, E. N, 9. E, 8. Mali T, 10. Tenet. That is the tenet is on that side. Okay, now. By the end of this lecture, you must be able to write down the coagulation cascade without any flaw. Okay, well, just remember that PTC is the basic tenet of hematology. PTT is the basic tenet of hematology. Tenet stands for 12, 11, 9, 8 and 10. Now we go to the Now, what are left out? Both intrinsic pathway, extrinsic pathway we have covered. 10 also we have covered. 5 we have covered. 2 we require. 1 we require. What are there in the common pathway? 10 must be there. 5 must be there. 2 must be there to become 2A. 1 must be there to become 1A. Okay. 10, 5, 2, 1 are tested in the common pathway. What is tested in the PT pathway? Prothrombin time test, what are you testing? Factor 7, factor 10, factor 5, factor 2, and also factor 1. Because prothrombin time is dependent upon the intrinsic as well as the common, isn't it? Both are there, both are required. When your prothrombin time is prolonged, either 7 is absent, or 10 is not activated, or 5 is missing, or 2 is missing, or 1 is missing. There is some problem with any one of these 5. So when I order a prothrombin time, I must remember these are the things I am testing. What am I testing? The lucky number 7, 10, 5, 2 and 1. Okay. Now, when I am checking the PTT pathway, what am I testing? 12, 11, 9, 8, 10, 5, 2, 1. Then I am not checking anything about 7 by doing that test. Now, let's go to the next one.
Tissue factor coagulation.
Thrombomodulin. There is one on the left-hand side. Thrombomodulin. TMPC, that is factor 2A, APC. Lot of fine-tuning is there. Unactivated platelet becoming activated, and then the 9, and then finally it has become factor 10A is formed. So my final step is 10 to become 10A, This 10A acts on the 2 to become 2A, that acts on the fibrinogen to become fibrin, and the amplification. This thrombomodulin is there in a very small way that is amplified to produce a big fibrin mesh. For the 10 to become 10A, I require the help of the intrinsic as well as the extrinsic pathways. Now, I'm simplifying the diagram. I'm making it even simpler now. Intrinsic pathway 12, 11, 9, 8. I forgot 10. No, not 10 is in the crossroad. 7 doesn't come here. 7 is on the other side. Okay. Prothrombin time or INR measures that particular segment, whereas our activated partial thromboplastin time measures this segment, whereas thrombin time measures this segment. You understand? Okay. Now, when you order a test, should order a thrombin time or prothrombin time or APTT, you have to see. PTINR SSS, what are the factors it assesses? It assesses 1, 2, 5, 10, and of course 7. Because the common pathway plus the left side path. Whereas APTT assesses what? It assesses factor 1, factor 2, factor 5, factor 10, and 12, 11, 9, and 8. Okay. And thrombin time assesses factor 1 and factor 13. 13 is the Fitzgerald factor. Okay. So this is the test. Now, if you go to multiple choice questions, everybody commits mistakes in the MRCP examinations because they are fundamentally they are not knowing what is the SAP. I see the answers, MRCP answers. They ask PT what it measures, they will not be able to say. Common pathway, what is the test, they will not be able to say. And the APTT pathway, what are the factors it measures, they are not able to say. Why? Because this training is not given to them. Understand? PTINR tests the common pathway and the extrinsic pathway. APTT tests the intrinsic pathway as well as the common pathway. Thrombin time does not test anything about intrinsic and extrinsic. Only tests from 10 down. 10 thrombin and fibrinogen. Did you get it? No. See. Now I need to know which drug works where. I am using anticoagulants. I must know which drug is working where.
So for activation of prothrombin to thrombin, only
prothrombin to thrombin is required by 10 to 10A. 10A activates prothrombin to thrombin.
No, sir, you told even without intrinsic factor, it will activate prothrombin to thrombin.
Intrinsic factor is absent, but intrinsic pathway is not there. Extrinsic pathway is working. 10 has become 10A, that is good enough to go down. This is not working, they are working, and 10 has become 10A, it is good enough to go ahead. So there could be diseases where intrinsic pathway is defective or extrinsic pathway is defective. Treatment is different, entirely different.
Basically, for the activation of prothrombin,
that is why we have to know.
Intrinsic and extrinsic both are.
And in all these things, Van Willebrand factor did not come. You see, with all 10, 11 and all, why that fellow is the fellow who is making first step, the platelet to adhere. Once the platelet don't adhere, nothing happens. So that is also a bleeding disorder, but it's not a clotting disorder. Van Willebrand factor disease is a bleeding disorder and not a clotting disorder. This understanding you must have. Now, you see, understand this diagram well. Okay, there is a disulfide bridge is there, and there is what is called disulfide ring is there, and fibrin polypeptides are there, protease sensitive sites are there. This fibrinogen has to become fibrin. For that, start with the intrinsic pathway, surface factor, also called the contact factor or HK or PK, 12 to 12A, 11 to 11A, calcium is required very much there, and then 11A acts on 9 to 9A, 9A in presence of calcium and phospholipids, and also with the activated factor 8, that will convert 10 to 10A. 10A once it is ready, again factor 5 is required. It comes in multiple steps. And calcium and vitamin factor 5 are required at multiple steps. You can see calcium here, you can see calcium here, you can see calcium here, you can see calcium here. Every step, calcium is a cofactor. Okay. Then there are phospholipids also are there. Phospholipids, calcium activated 10A, act on the prothrombin that converts into thrombin, that acts on the fibrinogen to become fibrin monomer. Fibrin monomer is one strand like this. It cannot do anything. It must become polymer. For it to become polymer, we require factor 12 and 13 should become 13A, and that becomes a fibrin polymer and cross-linked fibrin polymer. Now you see here. These are the fibrins, how they are bridged. The cross-linking is done by these fibrin bridges. This is accomplished by factor 13 becoming 13A. Okay, this is intrinsic pathway. Extrinsic pathway, some external injury has occurred. Why external injury should be protected? Intrinsic pathway requires clotting to happen inside the vasculature. Wherever is required, excess clot to be removed. Extrinsic pathways, when something is damaged. Okay, then you can't, where 12A, come on, we'll search for that, make him active, get him up, then 9A, then 8, then 11A, then 9A, then 8, it's a long time. Immediately, no, I am here, 7, come on, I will activate the 10 ferro. Immediately when there is an extrinsic injury, we don't depend on all the intrinsic enzymes and then factors at all. 7 itself is there. 7, where is it there? It is a tissue factor. The moment there is an injury, the tissue sector is a factor. That factor is the 7. And 7 can trigger 10 to 10A and everything is finished without the any problem with the intrinsic fellows. Okay. Intrinsic pathway is to keep the vasculature intact and get the circulation going. Extrinsic pathway is to tackle the external injury to the tissue. Understood? This should be shorter. This cannot ask for 20 fellows to do the work. One fellow should be able to activate 10 to 10A. That one fellow is the lucky fellow 7. Get it? Okay. Now 13 to 13A, the fibrin mesh is formed in which RBC, white cells, all the platelets, everything, the fibrin polymer to monomer and fibrin mesh is formed. Okay, fine. Now, where are my factors working? Heparin is a very powerful anticoagulant. Conventional heparin, 5,000 units straight away you give subcutaneous or intravenous. Earlier days, we used to say give intravenous, but subcutaneous is as effective as intravenous. You don't have to search for a vein in the emergency in a myocardial infarction. Straight away give subcutaneous 5,000 units of this one. It enhances the action of antithrombin 3, AT3. There is a substance called the antithrombin, which prevents the prothrombin to become thrombin. 10 makes the prothrombin to become thrombin, and AT3 just opposite of it, opposite of 10. So AT3, the antithrombin 3, it is a plasma protease inhibitor, 1,000 folds increased activity than antithrombin 3 and inhibits the clotting factors of proteases. Thrombin 2A, 1A, 10A, 9A, 11A by forming stable complexes and heparin. Where does heparin act now? Heparin is an antithrombin. Antithrombin means it prevents the conversion of prothrombin to thrombin. That way it prevents the clot. Where does it? It is the extraneous heparin, 1,000-fold activity than the intrinsic antithrombin. Whatever is there in the body, if it is 1 unit power, this is 1,000 units power, what you give from outside. That's why it quickly acts. Where does it go and catch? It gets bound to the activated thrombin. 2A is bound, likewise 11A is bound, 10A is bound, 9A is bound, 12A is bound. Everything in the intrinsic factor is attached by this heparin. You understand? Heparin goes and comes. It is a protein. heparin what you are giving, polypeptide. This polypeptide goes and makes complexes and binds. Antithrombin 3 is the polypeptide that goes and binds across all the intrinsic factor pathway factors and also the 2A. Okay, 10, 11, 9, 12, and also 2A are inhibited by the heparin. Many times, what are the loci or locations where heparin will act? The answer should come forth. It inhibits it is an antithrombin 3. The antithrombin 3 is a powerful protease inhibitor. It inhibits 11 thrombin conversion to thrombin A. It binds the thrombin 2A, thrombin or 2A. Likewise, it also binds to 11A, 10A, 9A, and 12A also. Almost all the levels of intrinsic pathway are blocked by the heparin. See? You should know where your drug is acting. Simply you can't push some drug and keep quiet. Okay? Now you are giving heparin. What test do you do to monitor the activity of heparin? What you must be doing? APTT or PT? Intrinsic pathway, entire thing is blocked, so you have to do an APT. If I want to titrate the heparin, I have to use APTT as the test, not prothrombin time or thrombin time. Understand why? It is attacking all the factors on the intrinsic side. Now, low molecular heparins. Low molecular weight heparins do not do anything with the other factors other than 10. That is why you don't require to monitor the level of coagulation by doing a APTT or any other test with the low molecular weight. Why? It only inhibits 10 to 10A, and that is why it stops clotting. It does not have to do anything with factor 30, factor 12, or 11, or 9, or 8. It doesn't have to do anything with those things. That is why we don't require to monitor the clotting time when you are giving LMWH. Understand logic? Now, heparins do not affect thrombin bound to fibrin or 10A bound to the platelets. That is a catch. Heparins, already some thrombin is bound to fibrin. It's not going to do anything. Or any factor 10A is bound to the platelets. It's not going to do anything. APTT activated partial thromboplastin time tests the intrinsic pathway. Means it's the monitoring test for heparin. Understood? Prothrombin time tests the extrinsic pathway. Warfarin interferes with the extrinsic pathway. That is why whenever you are giving a dicomarol or warfarin, you have to test prothrombin time. And prothrombin time is related to the reagent that you use. Instead of using simple prothrombin time, you have to use INR, International Normalized Ratio. Prothrombin time alone will not tell, because you have to compare with the control, compare it to the control, test how much it is, convert into a interpretable result called the INR. I will show you in the next slide. Okay. Now you see in the slide on the left side, heparin acts here. On what? Antithrombin 3. It affects all the factors in the intrinsic pathway and also 10A. So for the test for that is APTT. Whereas intrinsic pathway is activated through factor 7, and intrinsic pathway test is the warfarin interfere with the intrinsic path. Intrinsic path. Sorry, this is all the intrinsic pathway on this side. And the extrinsic pathway is the tissue damage factor 7 to 7A. That is inhibited by warfarin, and so I have to test the PD or prothrombin time. Now, I will give you a question. You answer that. I have tested a patient's APTT and PT and thrombin time. What did I test? All the three I tested. APTT normal. Thrombin time prolonged. PT prolonged. Where is the defect?
Extrinsic pathway.
Extrinsic pathway.
Extrinsic path. Kada?
Extrinsic.
Side. Another patient, APTT is prolonged, PT is normal, thrombin time is prolonged.
Intrinsic path.
This side. Another patient, APTT is normal, PT is normal, thrombin time is prolonged. Common path. See, three tests are there. APTT, PT, TT. TT is not tetanus toxoid. TT is thrombin time. Okay? Thrombin time is the shortest because it's very quick, no? 10, 2 to 2 years, 1 to 1 year. The shortest. Next shorter, longer one is PT. Even longer one is APTT. So, do 3 tests. APTT, PT and TT to know where is the defect. To locate the defect, you can say. These questions will come. A patient's APTT is prolonged of this much, normal value being this much, PT is normal, common this TTI is prolonged. What is the defect? Like that, you have to put answer. You get the scenario now. Okay? I'm again repeating. One patient has got APTT prolonged, thrombin time prolonged. PT-INR is not. Means my defect is either in the intrinsic pathway and also the final path, or together or at least the intrinsic path. Okay. Another patient is there. APTT is normal. PT is prolonged. Common pathway test TT also is prolonged. Means either there or here or a combination or exclusive there. How do I rule out? When these two are normal, only the common pathway test TT is abnormal. I know nothing is intrinsic, extrinsic, nothing in the intrinsic, common pathway problem. Okay. How do you keep the blood not clotted when you draw a blood? You add something to make it. What is that? Anticoagulant. What does it do? Why do you want to keep the blood fluid? Why do you want to anticoagulate the blood when you're taking a sample? If I want to test something in the blood, it should be available. What is the difference between serum and plasma?
Serum includes the cells.
Huh?
Serum includes the cells. Cells and plasma.
If you do not add, listen very carefully. This many students in YOC, they are not able to answer. That's why I'm asking. Huh?
Antibody related.
Tell me, take the blood, add anticoagulant, keep the blood fluid, spin it, supernatant is plasma, bottom is the clot. Bottom is the packed cells. After adding anticoagulant, take the blood, don't add anticoagulant, let the blood clot. What remains is serum. Serum is all the clotting factors are consumed. We allowed the clot to form. Whatever remaining after the clot is the serum. In plasma, we did not allow the clot to form. We have deliberately added anticoagulant, kept the blood fluid, and spun it in the centrifuge. All the heavy particles settle down. Supernatant will be plasma. Understand? Plasma and serum. Serum calcium or plasma calcium you want to test? Serum cholesterol or plasma cholesterol? Serum. So that is why what you have to do, allow the blood to not to clot by adding an anticoagulant. So take the blood, put it in a tube where there is an anticoagulant there. What is the common anticoagulant there? EDTA or any other anticoagulant, you know. What does those anticoagulants do? They absorb the calcium. Anticoagulant mechanism of action in the tube, not in the body. They take away the calcium. Once the calcium is not there, none of these chain of events will go because calcium is required everywhere. What you are doing? You are decalcifying the blood in a way. EDTA is a powerful calcium chelator. It takes the calcium away. Likewise, you know, any other fluoride you can add, sodium fluoride, sodium citrate, several anticoagulants are there. All of them, they take away the calcium. The mechanism of action of anticoagulation in the lab is by removing the calcium using an artificial agent. Now you understand what is serum and what is plasma. Serum is you allowed the blood to clot all clotting factors are consumed, the remaining is separated, and they say what is supernatant comes is that one is the serum, and below one is. Okay, in plasma, you allow blood, you allow the blood not to clot by deliberately adding some anticoagulant. Blood is fluid, spin it, superficial liquid is the above liquid is the plasma, below is the packed cells. Packed cells and plasma. Where do you want to test the sugar? In the plasma or in the serum? Blood sugar.
Sure.
That's why what you have to do, you should not allow the blood to clot. You have to add an anticoagulant. Which is the best anticoagulant to use when you are taking blood for sugar?
Sodium chloride.
Not certainly ADTA, not calcium citrate, not sodium citrate. Okay, you have to add fluoride, sodium fluoride. Sodium fluoride is the one. Lab also they will have sodium fluoride tube, separate tube will be there. Gray color tube. The color code is gray. Next powder will be added there inside, and then automatically it will be plasma. Plasma will remain. The centrifuge and take out the plasma, and that is why you have to say plasma sugar. Don't say blood sugar or serum sugar. Should say plasma sugar. Okay. Now you already know the test what you have to do. Now it's further simplified nowadays. Now with the 12 becoming 12A, 2 becoming 2A, 12 becoming 12A, and then you have you require the 9 becoming 9A, and then 11 becoming 11A, and 9 becoming 9A. Ultimately 10 becoming 10A. This is all the intrinsic pathway. Extrinsic pathway very simple. 7 has to become 7A. 7 is tissue factor. What are the drugs which act? Warfarin, dicomoral, and other drugs. These inhibit 2, 7, 9, 10, protein C and protein S. These are supplementary protein. Okay. Oral XA inhibitors. Says whatever you are giving 10A inhibitors. What are the 10A inhibitors? Rivaroxaban, apixaban, eptifibatide, several drugs are there, which are powerful 10A inhibitors. What are direct thrombin inhibitors? Jamilgatran, dabigatran, something like that comes. Tran. That is the powerful thrombin inhibitors. Now, what are the drugs we have? We have heparin, which acts on the intrinsic pathway, all the things including up to 10. We have warfarin dicomoral, which acts on the extrinsic pathway up to 10 and below. We have the direct thrombin, direct XA inhibitors like your apixaban, and then tirofibatide, eptifibatide, apixaban, these are the things. Direct thrombin inhibitors are dabigatran, and then jamilgatran, and other types of drugs. Okay, these are the various anticoagulants. Now, this also you must know, very important slide. Vitamin K, which is the antidote for these things. Vitamin K is the antidote. So look at this slide. You have this is the OH group, CH3 group, methyl group, and a radical there. Okay. This is called the reduced vitamin K. Reduced vitamin K. Why reduced? Because there are H ions here. In the OH there is H ion. Whereas here the oxidized one, there is no H here. H is missing. If you add H to this, it becomes OH here, and that is the reduced vitamin K, which is the active form of vitamin K. This vitamin K, what it will do? It will factor 2 will be there. There will be 10 glutamic acid residue factor 2, and the carbon dioxide also is required. Oxygen is also input, and then this higher protein carboxylase is the enzyme there, and then 2 is becoming activated 2 or the thrombin. What does this do? This goes and interferes here. Vitamin K supports this. All the drugs that you use are vitamin K inhibitors. They act here and they will not allow the vitamin K to do its role of forming 2 into 2A. Okay, normally what is happening? When the normal vitamin K is facilitating 2 to become 2A, Once that is done, whatever is left out, this becomes now oxidized. The oxidized one is called the epoxide from the vitamin A, which is an inactive metabolite. This epoxide has to become again vitamin K, active vitamin K, or reduced vitamin K. In other words, active vitamin K is reduced vitamin K, oxidized vitamin K is epoxide, is inactive vitamin K. For the inactive vitamin K to become active vitamin K, we require vitamin K reductase because reduction has to happen. My warfarin goes and interferes with the vitamin K reductase. So much so, active vitamin K is not formed, so coagulation is not prevented. Anticoagulation. Okay, that's how the vitamin K acts. Okay, this summarizes everything for you. Vitamin K, appearance, coagulation, cascade, platelet aggregation. Tests required in a bleeding disorder. Platelet count, BT, 1 millibrand factor, platelet dependent coagulation flow, PT, INR, APTT, TT, protein C and protein S, antiphospholipid antibodies. You have seen several places I have written PLPL. Those phospholipids are required for the coagulation. If there are antiphospholipid antibodies, those phospholipids are absorbed, they are not available. So clotting will be interfered. Mixing studies. So if you ask you to investigate a patient of thromboembolic pathophysiology, platelet count, PET, 1 milligram factor, platelet dependent coagulation flow, PTR, INR, APTT, TT, protein C, protein S, anti-PL antibodies, and other mixing studies. Okay. What is international normalized ratio? Thromboplastin used in the test is calibrated with reference to the preparation. What you have to do? Convert the prothrombin time ratio measured with locally prepared thromboplastin into INR using the following formula. What is that formula? Observed prothrombin time of the patient by control prothrombin time of a normal individual in the lab. Every day in the morning when the lab opens, they will take a 2 ml of blood or 1 ml from the lab fellow, and then they will prepare a controlled prothrombin time they will keep. And every patient test is compared to that observed prothrombin time of the patient divided by the control. For each patient, you don't have to do control. One control is enough for the whole day. Okay, and that control prothrombin time, observed prothrombin time by control prothrombin time to the power of ISI. What is ISI? ISI is a value, International Sensitivity Index. How do I know that? It is a measure of the responsiveness of the preparation, thromboplastin preparation. It is written on the vial itself. Most rabbit brain thromboplastins have an ISI of 2 or 2.6. The ISI value may range anywhere between 2.6. And whenever they are testing on the vial of the thromboplastin, there will be a number. That number you have to use to calculate. INR is equal to, now you tell me, what is INR? Observed prothrombin time divided by the control prothrombin time raised to the power of the power of the ISI. What is ISI? It is a value written on the wire. Okay? No. Almost over. Now you see. Thrombin, fibrinogen. Now we are using G2B3A receptor blockers also. Particularly in our cardiology, we use it. We use clopidogrel here. We use aspirin. We use clopidogrel. But this one is here. Clopidogrel acts here to here. That is. Aspirin acts on this particular cycle. Clopidogrel acts here. G2B receptors act here. So there are 3 types of antiplatelet agents we are having. One is aspirin, the other one is clopidogrel, the third one is G2B3A inhibitors. Where they exactly act, I have shown there. Okay, now I'm going to skip a few slides because taking time. Okay. VKA. What is VKA?
Vitamin K.
Vitamin K antagonist. Right? Like warfarin, coumarin. Factor 10A inhibitors. Like apixaban, tyrosine, and those. This one. Then thrombin inhibitors, dabigatran, and those. Okay. Platelet function, collagen and other mediators, thromboxane inhibitor, that is your aspirin, ADP, clopidogrel. Okay, aspirin, clopidogrel, pasugrel, ticagrelor are the ones they act here. They are the ADP inhibitors. ASA is thromboxane inhibitor, which is the ester salicylic acid. That prevents platelet activation. G2B inhibitors occur and the platelet aggregation they prevent. So where does my aspirin act? Where does my grels act? Clopidogrel, pasugrel, and then the ticagrelor, where does they act? And then where my iptifibatide, tirofiban, they act on here. These T2B, 2A, 2B, 3A inhibitors. Where my vitamin K antagonists act? Factor 10A inhibitors and thrombin inhibitors. Okay. So intrinsic pathway I want to block. Which drug I will use? Intrinsic pathway. Heparin. Extrinsic pathway I want to block. Which drug I use? Warfarin. Okay. I want to block the common pathway 10. Use rivaroxaban, apixaban, and endoxifen. No, I want to even go further down and use the thrombin inhibitor, direct thrombin inhibitor, dabigatran, jamelgatran. These are the drugs. Vitamin K antagonists act here, that is warfarin and coumarin. Intrinsic pathway drugs are affected by heparin. Direct thrombin inhibitors, rivaroxaban, apixaban, endoxifen act on the 10, and dabigatran acts on the 2, that is thrombin, direct thrombin inhibitor. Okay. Finally, every patient of bleeding disorder must have this belt, the chain on the arm. This is a medical alarm, medic alarm. And that is there. Either they are suffering from a bleeding disorder or they are taking anticoagulation. That is very essential. Okay. Who is following? Nobody follows this.
Everybody will have.
Okay. So we'll stop here. I hope you got a wonderful lecture. I love this lecture a lot. Very passionate.